Janekani. My teacher is John Colson, talking about the case 41 2015. A 14 years old boy with immune and liver abnormalities. Presentation of case Dr. Timothy Blacks, Pediatric Allergy and Immunology. A boy who was 14 years, 8 months of age and had multiple chronic illness was seen in the gastroenterology clinic of this hospital because he had an abnormal result of liver function test for approximately one period 5 years. The patient was born by vaginal delivery after a full return uncomplicated stem. He was noted to have a descendant testis. He received a diagnosis of gastroesophageal reflux disease and failure to thrive and fire, followed by type diabetes, mellitus, primary hypothyroidism at 4 years age, new speech delay learning, the delicious recurrent infection, peritonitis and pneumonias, bacteria and leukopenia of the touch. At 2 years of age, he underwent genetic evaluation in another hospital, and the chromosomes were respectively normal. You can see video.
Liver function tests can actually be very difficult to interpret. What I want to do is show you how I lay out my liver function tests in annotation form on a piece of paper and explain why I do that. I'll give you the basest form of clinical reasoning, that is, when you see an abnormality on the LFTs, what do you reflex? You should not reflex order these tests in every patient, but as you learn and begin to develop your skill in clinical reasoning, you'll see which ones you need at which times and which ones you don't. So we'll start off with the basest form of clinical reasoning, the reflexive tests based on the LFTs, and then we'll get into the more complicated task of actually interpreting liver function patterns and then some of the details that are contained within each 4 patterns. So let's start off just with the LFTs. I draw my LFTs a little different than most people in the country. This is the way I was taught to do it in my residency, and it makes a lot of sense. At the top is the total protein and the albumin. At the bottom is going to be the AST and the ALT. And I'm going to color code these for you. The total bilirubin can either be red or green, and you'll see what that means in a little bit. The D-bili goes next to the T-bili, and it's in green because it is associated with the alk-phos. Now, let's explore what the different meanings of each of these laboratory values and how you can be distracted by something that's not in the liver. These are going to be the reflex tests you order in order to begin to interpret LFTs.
An initial immunology evaluation revealed an immune-directed absolute T-cell count, a log count of class C3 memory B cells, 2.3% of total B cells alone, EGM level with normal levels of other immunoglobulins and low pneumococcal antibody titers after repeat vaccination with the 33 Balem, no bags. You can see bleeding.
Oh, hello, my name's Tom Valumy. I'm a senior lecturer here at the Blizzard Institute at Queen Mary University of London. And first of all, I'd just like to thank the JCI for giving us this opportunity to make this video and of course for accepting our paper for publication. Our group's been involved in studying this rare bone marrow failure syndrome called disc keratosis congenita for quite a number of years now. We first got into this subject really through my colleague Inderjeet Dokal, who recognised this as an interesting syndrome that was not really being well studied. So DC, this disc keratosis congenita, is clearly a heterogeneous disorder, both genetically and phenotypically. Patients present with a kind of big range of symptoms and spectrum of disease, from late onset to very early severe cases, with multi-system disorder affecting multiple tissues. Through the efforts we've made at identifying genes that cause this disease, we now believe that the underlying basis is a defect in telomere maintenance. So this study really begins with a family from Birmingham referred to as two very young children, presenting the age of 3 and 5 years, with classic features of the disease, mucocutaneous features, bone marrow failure. Interestingly, neurological abnormalities is cerebellar hyperplasia, and the hallmark of the disease, very short telomeres. It was Amanda Waln in the lab who first picked up from exome data. Exome sequencing data is our ability to sequence all the coding regions of the genome. She picked up on this homozygous missense variant in the 2 affected children. Interestingly, we then found a second individual, homozygous again, this time for a splice site variant, again from Pakistani origin, consanguineous families. And this would, we know, to give rise to a small deletion in the protein sequence. And for me, the clincher was when we found the third family. Now, this person was a compound heterozygote for these 2 indels, and this predicted to give this small deletion to the protein, one of them, the other one a truncating protein. And it was this third family that really made this gene, PARN, beyond doubt the disease-causing gene. I was very lucky then at this stage to have Hemant Tumala in the lab who picks up the story and was able to run away with it.
Hi, I'm Hemant Tumala, postdoc under Dr. Tom Valumy and Professor Inderjeet Dokal. When Tom and Amanda picked up this gene that is shown to be mutated in 3 unrelated families from 4 individual cases, and indeed it is very significantly shown to be a standout gene from all the others, and it has no previous connection to the telomere biology, I thought this is a bit quite challenging. So what is PARN? PARN is a poly-A-ribose-specific nuclease, and it functions as an exonuclease enzyme. The assays that for PARN's function have been well characterized, and we adopted a particular assay called in vitro deadenylation assay. So in order to perform this assay, we need obviously the patient sample. So here we have the patient sample, and we need a RNA substrate which has a poly-A tails. And when I did this assay, this is where something interesting started to happen.
Okay, well, I just want to take you back to that amazing day when Hemant brought me down to the lab and showed me this beautiful gel. What I love about this gel, the beautiful blue colour on the white screen, the lovely fleck to the uncut fragment here, the untrimmed fragment here. There's clearly something going on down here where we're seeing cleaved products or trimmed products. But what jumped out at me straight away was this middle track here. There's a clear ladder showing, which is not seen in
Dr. Walter with the diagnosis of selective antibody defense, the patient was eligible for immunoglobulin replanted therapy. The patient underwent this treatment in combination with the administration of prophylactic antibiotic agents, and they had the aggressive frequency and duration of upper respiratory infection. Stem cell transplantation is not considered For immune dysfunction sees the contribution of the immune system to the overall progression of disease in prion. You can see linear.
I am Dr. Mark Ballow. I presently reside in Florida and am on the part-time faculty at University of South Florida in the Pediatric Allergy and Immunology Division that's in St. Petersburg, Florida at All Children's Hospital. I'm going to talk to you today about one of the Choosing Wisely topics as follows. Don't recommend replacement immunoglobulin therapy for recurrent infections unless impaired antibody responses to vaccines are demonstrated. This is Choosing Wisely topic was developed because many physicians used replacement immunoglobulin therapy inappropriately where they had not demonstrated the fact that these patients had an underlying immune deficiency disorder. So certainly there are patients who have significant hypogammaglobulinemia, less than 400 or 450 milligrams per deciliter, recurrent infections, and by and large those patients indeed don't respond to vaccine challenges, so clearly fall into the category of primary antibody deficiency disorders. However, there are other patients who have fairly normal serum immunoglobulins, and I'm talking here about serum IgG, who may also have recurrent infections and the inability to respond to vaccines. And we call these patients selective antibody deficiency. And these patients may also be amendable to replacement gamma globulin therapy. However, it's critical that in patients who have fairly normal levels of serum immunoglobulins, that we evaluate or work up those patients to determine their response to antibody vaccines